So we'll move on to the next portion of today's program. So Dr. Chen is Assistant Professor of Medicine at University of Chicago, focusing on breast cancer. So like Dr. Trujillo was saying, breast cancer is a very, very high yield area. So Dr. Chen is going to go over some sample exam questions and then guide us through how to tackle these questions. So take it away.
Great. Good evening, everybody. Thank you so much for the kind introduction. We're going to be going through some questions relating to breast cancer. Please feel free to ask questions while I'm talking, and we'll try to leave a couple minutes at the end to go over any last minute topics. So the first question, a 57-year-old woman with metastatic ER positive, PR negative breast cancer presents to your clinic for a second opinion. She was initially diagnosed with T2N1 ER positive, PR negative, HER2 negative left breast cancer. She underwent adjuvant chemotherapy and adjuvant anastrozole was initiated. She had completed 3 years of anastrozole when she developed some left wall skin nodules, and a biopsy revealed recurrent breast cancer that's also ER positive, PR negative, and HER2 negative. Staging scans showed metastasis to mediastinal lymph nodes and bilateral lungs. Her endocrine therapy was switched to exemestane and palbociclib, and after 8 months on this therapy, progression in her lungs was noted. Her prior physician had ordered genomic profiling on her tumor tissue, which revealed a PIK3CA mutation. What would you recommend? A, continue exemestane and switch palbociclib to abemaciclib. B, stop exemestane and palbociclib and start tamoxifen and everolimus. C, stop exemestane and palbociclib and begin tamoxifen. Or D, stop exemestane and palbociclib and begin fulvestrant and alpelisib. So the correct answer to this question is going to be D. So one of the hardest parts about the oncology boards is that you can have these very long question stems and you can get very lost in kind of the patient scenario. And so trying to distill what the question is very quickly will be a really good skill to learn. So ultimately, this patient has a metastatic ER positive, HER2 negative breast cancer, and she also has a mutation in the PIK3CA gene. She has progressed on a CDK4/6 inhibitor. So in a randomized phase 3 trial, we know that treatment with alpelisib and fulvestrant prolonged progression-free survival compared to fulvestrant and placebo. And for this patient with a PIK3CA mutation, this would be the next recommended line of therapy. And so NCCN guidelines also recommend assessing for PIK3CA mutations on either tumor tissue or in peripheral blood to determine which patients are eligible for this treatment. The other treatments are alternative endocrine therapies that would not be the most appropriate for this patient. A 36-year-old woman presents to her primary care provider for routine health maintenance. She has a history of unfavorable early-stage Hodgkin lymphoma, for which she received chemotherapy and mediastinal radiation at age 25 years. She has no evidence of recurrent lymphoma, and she's asymptomatic, and she asked whether any additional tests are now indicated for screening. Which of the following tests should you order now? A, an MRI of the breast, B, a mammogram, C, a CT of the chest, or D, no additional testing is indicated. So in this question about a patient who previously received mediastinal radiation, the correct answer is B, she should be offered a mammogram. So women who received radiation therapy near breast tissue are considered high risk and they need earlier screening. Mammography should begin 10 years after radiation completes or at age 40, which is the standard year at which we would start mammography screening for average risk women, whichever is first. There's currently no role for MRI screening on its alone. You can consider MRI screening in conjunction with mammogram screening for high-risk patients such as this one or in patients with germline BRCA mutations, but currently there's no role for MRI screening alone. And a CT chest would not be the best to evaluate for the development of breast cancer, and not offering any breast cancer screening at this time would not be appropriate. So this question kind of started out talking about lymphoma, but ultimately turned into a breast cancer question. So again, thinking about what the actual question they're trying to get at is important, so you can get through the answer choices quickly. A 65-year-old male undergoes a mastectomy and sentinel lymph node biopsy. He's found to have a 2-centimeter invasive ductal carcinoma, grade 1, with no evidence of sentinel lymph node involvement. Tumor testing reveals strong estrogen and progesterone receptor staining, more than 90%, as well as a HER2 negative status. Genetic testing reveals he has a deleterious germline BRCA2 mutation. Which adjuvant therapy do you recommend for this patient? A, tamoxifen, B, enzalutamide, C, an aromatase inhibitor, or D, olaparib? So in this case, for this patient with an early stage ER positive, HER2 negative male breast cancer, tamoxifen is the preferred agent. Enzalutamide is used in prostate cancer therapy, but it is not a standard agent in managing curable male breast cancer. Olaparib has recently been approved for patients with germline BRCA mutations or patients with metastatic HER2 negative breast cancer. But in ER positive patients, adjuvant olaparib is recommended only for patients who have greater than 4 axillary lymph nodes if they had surgery first, or in those who had residual disease and a CPS plus EG score of 3 or greater if they were treated with neoadjuvant chemotherapy. And this is based on the phase 3 Olympia trial. And thus, olaparib is not recommended for this patient. The vast majority of male patients with breast cancer will have ER positive, HER2 negative disease. In many ways, we treat these patients very similarly to female patients. Tamoxifen is the preferred agent. If there's progression on tamoxifen, then aromatase inhibitors can be given, but they should be given with agents such as Lupron, so GnRH agonists. If patients develop metastatic ER-positive disease, then it would be the same pathway as in female patients, including CDK4/6 inhibitors and other endocrine agents, and then chemotherapy when they become endocrine resistant. A healthy 35-year-old woman is 22 weeks pregnant and presents after noticing an enlarging mass in her right breast. She underwent a mammogram and an ultrasound, and findings revealed a suspicious right breast mass at the 11 o'clock position, measuring 5.2 centimeters in the greatest dimension, in addition to suspicious right axillary lymph nodes. Biopsy of the breast mass and the right axillary lymph node reveals invasive ductal carcinoma that was estrogen receptor 5%, progesterone receptor 2%, and HER2 negative. Which of the following staging studies is appropriate for this patient? A, no staging studies are indicated. B, a chest radiograph with abdominal shielding and a complete abdominal ultrasound. C, a CAT scan of the chest, abdomen, and pelvis. Or D, a PET scan. So in this patient who has stage 3 disease, she has a tumor that's larger than 5 centimeters. She has positive axillary lymph nodes. NCCN guidelines would recommend systemic staging, and thus no further imaging would not be appropriate. However, in pregnancy, we are limited in the staging that we're able to offer, and the best option for her would be a chest X-ray with abdominal shielding and a full abdominal ultrasound. If this patient were not pregnant, then a PET scan would be appropriate, or a CAT scan as well as a nuclear bone scan to make sure we get bone imaging. Either of those options would be appropriate in a non-pregnant patient. A 67-year-old female with a past medical history of hypertension, diabetes, and osteoarthritis presents with a new diagnosis of ER negative, PR negative, HER2 0, metastatic to the bones and liver. Further testing reveals no germline BRCA mutation, and her PD-L1 CPS was 1. She receives single-agent Taxol, and she's here to review her imaging results after cycle 9, which show progression of disease. What would be the next best option for her next line of therapy? Would it be A, eribulin, B, sacituzumab govitecan, C, trastuzumab deruxtecan, or D, talazoparib? So this is a patient with metastatic triple-negative breast cancer and a negative PD-L1 score. She received single-agent chemotherapy as her first line of therapy, and now we are looking at what would be next. So we know based on the phase 3 ASCENT trial that sacituzumab has a better progression-free as well as overall survival compared to chemotherapy in the refractory setting, and thus eribulin would not be the best answer in this choice. The patient is HER2-0, and so currently would not be eligible for treatment with trastuzumab deruxtecan. HER2-low would be considered either HER2-1+ on IHC or HER2-2+ with a negative FISH. And the patient is BRCA wild type and thus would not be eligible for talazoparib. So in this situation, sacituzumab govitecan would be the best treatment option for this patient at the time. A 48-year-old female with no significant past medical history presents with a newly discovered 3-centimeter mass in her right breast. She has a palpable finding in her axilla. Both are biopsied and show grade 3 invasive ductal carcinoma, ER negative, PR negative, HER2 negative, with a Ki-67 of 65%. What is the appropriate treatment course? A, weekly paclitaxel followed by dose-dense AC. B, taxotere and cyclophosphamide every 3 weeks. C, pembrolizumab in combination with paclitaxel, carboplatin, adriamycin, and cyclophosphamide. Continue pembrolizumab until surgery and stop. Or D, pembrolizumab in combination with paclitaxel, carboplatin, adriamycin, and cyclophosphamide. Continue pembrolizumab after surgery. So the patient in this case has a stage 2 breast cancer. She has 3 centimeters of disease in her breast, as well as a positive lymph node. The standard of care for stage 2 and stage 3 triple negative breast cancer is currently chemoimmunotherapy with adjuvant immunotherapy, regardless of response at surgery and regardless of PD-L1 status. In this patient with no past medical history and no intervening medical comorbidities, she should receive the standard of care. You've referred a healthy 62-year-old woman following partial mastectomy with sentinel lymph node biopsy. Final pathology reveals a 3.5 centimeter invasive ductal carcinoma, grade 2, with a Ki-67 of 15%. She's ER positive 99%, PR positive 90%, HER2 negative, with 1 out of 3 lymph nodes involved with macrometastatic disease without extranodal extension. Her breast surgeon requested an Oncotype DX, and the recurrent score is 21. Which of the following is the most appropriate next step? Adjuvant chemotherapy with Taxol followed by AC, adjuvant chemotherapy with docetaxel and cyclophosphamide, whole breast radiation followed by aromatase inhibitor for 5 to 10 years, or whole breast irradiation followed by tamoxifen for 5 to 10 years. So this is a patient who has a postmenopausal patient with an ER positive, HER2 negative breast cancer. She has a low Oncotype score and thus should not receive chemotherapy. Postmenopausal patients with an Oncotype score of 26 or greater will see a benefit from chemotherapy, but hers was 21. This patient would benefit from adjuvant radiation because she had a partial mastectomy and also because she was lymph node positive. Aromatase inhibitors are the preferred class of agents in postmenopausal patients as compared to tamoxifen. The length of time of adjuvant endocrine therapy does remain controversial, but patients should receive at least 5 years with consideration of additional therapy for patients with high-risk disease. A breast cancer index, which is another genomic test, can be sent at 5 years to help determine the potential benefit of extended adjuvant endocrine therapy. Patient is a 65-year-old female with de novo stage 4, ER positive, PR positive, HER2-1+ on IHC breast cancer, which has spread to her bones. She has received palbociclib and letrozole and progressed after 2 years of treatment. She then received fulvestrant and everolimus and progressed after 10 months. Following this, she received capecitabine and progressed after 10 months. Next generation sequencing did not reveal any somatic mutations, and she is now presenting to discuss next steps. What should be offered as her next line of therapy? A, elacestrant, B, trastuzumab deruxtecan, C, paclitaxel, or D, eribulin? So the patient in this case has an ER positive, HER2 low breast cancer. She has progressed on multiple lines of endocrine therapy as well as one line of chemotherapy. This is a patient that would have been appropriate for the Destiny Breast 04 study. And this demonstrated that trastuzumab deruxtecan in patients who are HER2 low demonstrated both an improvement in progression-free survival as well as overall survival with TDXD as compared to chemotherapy. And so neither paclitaxel nor eribulin would be the appropriate treatment of choice in this patient. And without an ESR1 mutation, elacestrant would not be appropriate. And so the correct answer should be B, trastuzumab deruxtecan. And that is it.
Well, thank you again, Dr. Chen, for sharing
of
this.
course. I wish everyone the best of luck.